second speaker, not the first, so you guys woke up with your coffee yet. Just a quick introduction to myself. I'm Shawn Needham. I'm a pharmacist, graduated from the University of Washington in 1994. Seemed like just yesterday. I am a clinical assistant professor at the University of Washington and teach the advanced compounding course there. And I just want to introduce my wonderful wife. She's also a pharmacist. She's in the audience trying to video me. We're going to try to put it on YouTube. So I'm going to go through some of this fast, and I want to save some time for case study at the end. So that's right, it's backwards. Okay, there we go. Okay, so I want to get these definitions out of the way, and because you guys are hearing this from your patients, right? Well, I want natural thyroid only. I want natural thyroid only. I don't want anything synthetic. Okay, well let's just define this. So there's a difference between synthetic, natural, and bioidentical. So synthetic means it's synthesized in a lab, correct? That doesn't necessarily mean it's not bioidentical. For instance, thyroid, levothyroxine and levothyroxine, T3 and T4, they are synthetic, absolutely. They are made from L-tyrosine and iodine. They are synthetic, made in a laboratory, but they are exact copies of what are in your body. So they are bioidentical. Bioidentical, exactly what it means in Latin. Bio, life, identical. Identical to what's in your body, okay? The only natural thyroid, truly natural thyroid, that's non-synthetic would be porcine thyroid, which USP porcine thyroid, some brand names are Armored Thyroid, Nature Thyroid, you may have heard of those. Those are natural. They are natural from pig source. So they are natural to a pig, they are not natural to a human. It's like comparison of Premarin. Premarin is natural. Premarin is natural to a horse, it's not natural to a human. So that's the analogy there. I got to go over this too because we link hormones into such a broad category. We say, oh, you know, like for instance, if somebody's had breast cancer, they got to go off hormones. Let's be more specific than that. Hormones are, it's a very, very broad category. I'm guilty of saying hormones in a broad way. I'm even guilty, I can even be guilty of saying estrogens and link all the estrogens together, and they're different also. So let's realize there are different hormones. For instance, in the adrenals, adrenaline, right? Epinephrine, that is a hormone. Insulin is a hormone, okay? So we are mostly going to talk about thyroid today, and of course thyroid is produced in the thyroid gland. So thyroid hormone. I talked about it a little bit already. Levothyroxine, also known as T4. Why is it called T4? Because it has 4 iodine molecules. It is literally L-tyrosine and 4 iodine molecules. A pretty simple structure, okay? It is the inactive form of thyroid. I say inactive. Really what it is, it's less potent than T3. So it has to be converted, and it has to be converted to T3 in order to be more active in the body. T3 is a more active form of thyroid. And T3 is just like T4, except it has 3 iodine molecules instead of 4. It is also known as levothyroxine. Low thyroid symptoms. So depression, weight gain, hair loss, decreased libido, brittle nails, constipation, increased sensitivity to cold, fatigue, high cholesterol. So we see these symptoms all the time. Here's what I ask you guys to look for when you're thinking about thyroid possibly. Depression. So how many times do we see a male or a female come into our offices or clinics and they're 45 to 50 years old and they're depressed? And so what do we normally do? We prescribe an SSRI, right? Think about that though. Think about their thyroid, okay? Same thing with weight gain. Same thing with high cholesterol. Thyroid metabolizes cholesterol. As we age, our thyroid levels go down. That is just a fact. That's a fact of life. Most all of our hormones go down. There I am. I'm putting hormones all into one category, but most of our hormones do go down as we age. So high cholesterol, when you look at a patient and they're 45, 50 years old, and they have high cholesterol, don't necessarily think that they have a atorvastatin deficiency, okay? They may have a thyroid deficiency. Also realize this, just a little note, that testosterone, low testosterone symptoms mimic low thyroid symptoms, so you really have to monitor them. So I'm going to go into some of the commercially available stuff, which you guys may be a little bit more familiar with. So Synthroid is levothyroxine. There's many generics available. It is the most popular thyroid. In fact, I think in 2016 it was, or 17, it was one of the most popular. It was the most popular drug prescribed. Cytomel is liothyronine. There are generics available. Both of these are immediate release. One of the problems with L-thyronine and Cytomel, the commercially available, is T3 liothyronine has a short half-life. It has a half-life of, like 4 to 6 hours, depending on the person. So, so it wears off pretty fast. So it doesn't last all day long. I talked about this a little bit. Armored thyroid, isolate from pigs. There is some problem with it. Has anybody ever smelled armored thyroid or porcine thyroid? I mean, it stinks, right? I mean, not a surprise. It is literally ground up pig's thyroid. That's literally what it is. And then they standardize it to a T4, T3 ratio. So there's 38 in 1 grain. There's 38 micrograms of T4 and like 9 micrograms of T3. Now, I can tell you this, it is very, very confusing to most pharmacists and most clinicians when you're trying to explain what 1 grain porcine thyroid is, because 1 grain is an apothecary form of saying 65 milligrams. So when somebody sees somebody on 65 milligrams of thyroid, they're kind of wondering, well, how do I transfer them over to levothyroxine? Or, but that's why you have to understand how much actual active ingredient of the T4 and T3 is in 1 grain of thyroid, which is 38 micrograms of T4 and 9 micrograms of T3. So another problem with that is that ratio is set. So you can't change that ratio. So if they have too much T3, and you want to give them more porcine thyroid, you're going to give them more T4 and more T3. So they might not need that. So that's one of the issues. Also, because it comes from an animal source, there are some patients that have reactions to it, producing antibodies to it. So the thyroid, let's go into some history of thyroid. So thyroid has been treated since the 1800s. We know that. It started out with thyroid extracts, and in 1934 is when USP desiccated thyroid came out. So Nature Thyroid, Armour Thyroid, the active ingredient is USP desiccated thyroid, porcine. So 1934, that is pre-FDA. So they were grandfathered in, which means that Nature Thyroid and Armour Thyroid have never been FDA approved. Now that's not necessarily a bad thing. There's a lot of drugs that have been grandfathered in. A few of them, codeine. Codeine is not really FDA approved. It's been grandfathered in because it was around before the FDA was. What does that cause, though? That will cause some issues of supply, because the FDA does not like anything that's not FDA approved. So as you guys have noticed, acetaminophen, which is grandfathered in, codeine, which is grandfathered in, USP thyroid, sometimes those things are harder to get now because the FDA does not want them on the market because they're not FDA approved. So even though porcine thyroid has been used for years with no issues. There's that ratio again. I talked about that a little bit. Anytime we have an animal product or a plant product for that matter, where you I try to standardize something from multiple ingredients that are in that product, there's other things in there that we don't know. So we do know that in USP porcine thyroid that there's iodine in there, because it's a thyroid gland. T1 in there, but we only know what's in there if we know what to look for. So if we don't know what to look for, we don't know what all is in there. So there's a lot of things in there that we don't know. Now, here's another thing too. With those type of animal products, whether it be porcine thyroid or whether it be Premarin, for instance, there is no way in today's environment they would ever be FDA approved. Because in order to be FDA approved, you have to show what all is in your drug formula, and they don't really know what all is in that. So it's standardized to something, but we don't know what else is in there. So the immune reaction or antibodies I talked about, that can be a problem, especially patients with Hashimoto's disease. Here's another thing, strict vegans. You know, it's a pork product, and some people don't know that, and when they find out and they've been taking it, they can get upset. So be aware of that, and kosher patients, of course. And of course, porcine thyroid is immediate release. It's not sustained release. Levothyroxine, T4, also known as L-thyroxine, isolated in 1914, synthesized in 1927. It didn't become standard over the porcine thyroids until the 1960s. And yeah, it's the most commonly prescribed drug in 2016. Actually, I mean, it is a popular drug. That kind of surprised me, but that just shows you how many patients have hypothyroidism. Here's an interesting thing about levothyroxine. It's got a long half-life. So it's got a half-life of 4 to 6 days. So it's a longer half-life. And it's a standard therapy for sure for hypothyroidism. So liothyronine, you know, it's a T3, also known as T3. It's 4 times as potent on the receptor site as levothyroxine. Shorter half-life, and this is very, very patient-specific, like most drugs. Shorter half-life, 3 to 8 hours. It does not affect TSH. Now, here's what's normally the case when you see this, though. When you don't normally always dose with just T3, although in theory you could, but it usually just doesn't work that way for a multitude of reasons, partly because we are so used to seeing levothyroxine that we just prescribe it also. But in theory, because T3 is the active, is the more potent, you could prescribe this T3. Now realize you couldn't do it just once a day with the commercially available products. You would have to do it multiple times per day because it has a short half-life. So that's usually also why levothyroxine is prescribed. And it's just standard, and it's been marketed very heavily by drug companies. And it was isolated in 1953, approved for use in 56. So basically what I'm saying about TSH is usually you do see their TSHs move because they're also on levothyroxine. So what causes poor thyroid function? Obviously, we're not producing enough hormone is one of them, but what causes some of the other issues like decreased conversion of T4 to T3 is definitely a problem. So your T4 could be normal, your TSH could be normal, and we'll get into that a little bit later about what normals are. But if you don't have enough T3, you will have symptoms of low thyroid, and it's important to recognize that. That's why I think it's important to check T3. Some other things that can cause it is increased binding. If thyroid, thyroid is a hormone that can bind to proteins. So when they bind to those proteins, they cannot be effective at the receptor site. So increased protein binding. Some of the things that can cause that is estrogens, high cortisol levels, birth control pills can all cause increased binding. So hormone not working at the receptor site, Hashimoto's where you actually have immunities to the thyroid. What are some of the things that affect increase in binding or decreased conversion? So nutrient deficiencies, obviously iodine. If we don't have enough iodine, we're not gonna produce enough thyroid. Selenium, vitamin D. Don't forget about vitamin D. If there's one supplement your patients can take, forget about multivitamins, forget about fish oils, vitamin D. If there's one, I'm not saying multivitamins and fish oils aren't good, but if there's one, it's vitamin D. Vitamin D is great for seasonal affective disorder. Part of the reason why is because it affects thyroid function. So, and make sure they get enough vitamin D. 400 units is not enough. They need 5 to 10,000 units a day. So yeah, increased binding, estrogen, birth control pills. They have prednisone. So realize that when somebody goes on a course of prednisone, it can affect their thyroid. Don't get too jumped up over it, and treat patients on lab levels. And even though the labs will be affected, don't necessarily worry about that because the prednisone, their thyroid should stabilize again. And then aging, alcohol, stress, cortisol, the adrenal glands is very important. While talking about that, we have a hierarchy of hormones in our body and glands. So, and it goes like this: adrenal glands, thyroid, ovaries, and testes. And the reason I talk about this is because if patients' adrenal glands are not in balance, if their adrenals are all over the place, i.e. they're not sleeping and their cortisol is high all the time from overstressed, their thyroid won't get better. It might get better, but they will not feel optimal. And here's the way I like to explain it. Adrenal glands trump everything, right? We will die without adrenal glands, right? We will not live without adrenal glands. Thyroid, we can live without a thyroid. It won't be very fun. And we can live without our ovaries or testes. So if the adrenal glands are not in balance, the other things will not get, the patient won't feel optimal. So realize that. And that's a whole other topic. I could talk about 8 hours on adrenal function. So history of thyroid disease, or history of thyroid testing. And here's what's, I love talking about this because sometimes we get so worked up on testing and labs being black and white. And all I can say is we treat patients, we don't treat lab levels. And that should be with most any labs. But unfortunately today in medicine, I don't see that happening. It's, it's black and white. If, one number is normal and you're one number over that and, you're not normal. So realize there's a difference between being normal and being optimal. So iodine, many years ago, we used to test thyroid function by iodine. There's still some clinicians that do that, and you can do the iodine paint test and stuff. I'm not totally against that, but it's interesting how thyroid testing has progressed. So then we got in the 60s, I think, to TSH testing. Well, then we found out that the TSH testing wasn't really sensitive enough. So in the 1980s, there was a new TSH test. So that's more sensitive. And TSH is still the gold standard for thyroid. But there again, symptoms and history, and realize. So testing of thyroid came out in the 60s, right? When did Armour Thyroid come out? 1934. We've been treating thyroid problems way before we had testing. Great story. So I was born in Othello. I have a twin brother, and the physician that delivered me in 1970 retired just a few years ago. Dr. Richard Untitled Othello, a wonderful guy. His son is also a physician. And one time I was doing a presentation on thyroid. This is probably about 15 years ago, maybe 10 years ago in Othello. And Dr. Bunch started practicing in like 1962. And I'm doing a presentation, and I'm talking about thyroid testing and TSH and how we should test T3 and the importance of patient symptoms and history. And I said, Dr. Bunch, so, because one of the providers asked, well, we got to, what if their TSH is normal? We got to test TSH. And I said, Dr. Bunch, so back in 1962, when you first started practicing, what did you do with thyroid? Well, we would give them an exam and palpate their thyroid. That's interesting. I don't know if that happens much anymore, but that's something that's very important, physical exam. And we'd ask them about symptoms, and if they had all those symptoms I was telling you about, or some of the symptoms, we would give them a trial of thyroid. We'd see how they did, and if they did better, and they didn't have side effects, but they weren't quite optimal, we'd give them a little bit more. So it just shows you that, we could treat thyroid before we had thyroid tests. So, and in the 60s, there was total T4 and total T3. Again, the problem with that is that's the total amount of hormone in the blood. That's not the free hormone. And total amount of hormone is kind of useless because it will not hit the receptor site because it's protein bound. For the T3, the TSH first generation, thyroid binding globulin is how we find out how much thyroid is protein bound and get a free level. So after we found that, the free T3 and free T4 followed a few years later, of course. So TSH is a gold standard of thyroid testing, right? Is TSH a thyroid hormone? TSH is a pituitary hormone, right? This is the comparison I like to make. And I'm not saying we should check TSH. I think because it's so gold standard and it's so popular, I think we should check it and monitor it. And I think TSH is a good screening tool. I don't think it's the best tool when you're on therapy. And here's why. TSH is a pituitary hormone. It's a negative feedback loop. So of course, the more TSH you have, thyroid stimulating hormone, your pituitary is telling the thyroid, we need more thyroid because your thyroid levels are low. So TSH goes up and tells you to make more thyroid. The problem with that is that when you go on therapy, TSH can be changed in like over a 30-day period or a 60-day period. TSH can be affected by one dose. If they miss one dose of their thyroid over a 60-day period, it can affect their TSH. That's one of the problems. Whereas if you're monitoring T4 and T3 levels, you're monitoring basically what they're doing that day. So if they're taking a drug that day, you're monitoring their levels from that day. There's some problems with that too. We'll get into that. But here's one of the issues with here's what I like to make the analogy of. When we check testosterone levels, right, and we are monitoring men on testosterone, does anybody do that? Show of hands. Interactive portion here. Okay, perfect. So when we monitor men's testosterone levels, do we check LH and FSH? We don't. So to me, why do we check TSH levels still when they're on thyroid hormone? Shouldn't we check free T3 and free T4 levels? That makes more sense to me. Again, I'm not saying TSH is necessarily bad. I think it's a great screening tool. But I think when you're on therapy, you need free T3 and free T4 check. Let's see. So, how often? Here's what I don't like about TSH, and we have changed this a little bit over the last few years. The endocrinologists have changed some of their recommendations, but when you look at a TSH lab, what's normal? 0.5 to 5. Now it depends on the lab. Some of them are 0.5 to 4, but still, when you look at that range, 0.5 to 5, that is a huge range. So, what do I see commonly? Well, my doctor checked my thyroid. I have all these symptoms of low thyroid. And my doctor checked my thyroid and it was normal. Well, what was it? What was your TSH? Well, they only checked my TSH and my TSH was 4.9. But I'm depressed, I have weight gain, I have decreased libido, I have brittle hair, I have brittle nails. But the doctor told me, my TSH is 4.9, so it's normal. Well, normal is not always optimal. And obviously that patient is showing symptoms of low thyroid. So what was their TSH? Let's say that's a 50-year-old woman. What was their TSH when they were 25? We don't usually have a baseline. Sometimes we do, sometimes we don't. And that might not necessarily with TSH. It can vary a lot through your life too. So the important thing is what's optimal. And I think a lot of the endocrinologists have said TSH below 2 now is what I see. Let's see. So one of the nice things about when a compounded prescription is that you can make a sustained release T3. So in a compound pharmacy, they can make up a sustained release T3 that can last 8 to 12 hours all day long. And that is a benefit when it comes to dosing T3 for sure. And not only that, but you can also change, with compounding, you can also change the ratio of the T3 to T4. So if they don't need more T4, just need more T3, you can give them just more T3. I'm not going to talk about this a lot. It's in your slides. But again, on adrenal function, if the adrenals are not in balance, the thyroid is not going to go into balance. Or the patient won't feel optimal. So think about that. Vitamin D, again, I didn't know we had an audio here. Vitamin D, I talk about that because I've seen so many patients. I feel... I remember one time a patient came in to me and we were balancing her thyroid and her other hormones, and a year later she came in. I said, well, how are you doing? And she said, well, I'm doing much better. She said, about 3 weeks ago I started vitamin D and I'm doing much better. And I really felt bad that I didn't recommend that to her. So I tell everybody about vitamin D because it's a wonderful, wonderful supplement. It's actually a hormone in itself. If you look at vitamin D, it's got a cholesterol backbone like a hormone. So it does many more things than just bone health. It does a lot of things in the body. Okay, testing. Testing the thyroid function. So I kind of hit it a little bit, but I believe that a complete thyroid panel, and I used to tell providers when they say, well, what do you want to test for thyroid? Well, we need a complete thyroid panel. Well, I will tell you, don't just think that every lab has a different term for complete thyroid panel. So don't necessarily think that that's going to be the catch-all. Because really the most important, obviously the most important is free T3. But I also recommend TSH and free T4. And with those three, you can get a pretty good idea of what's going on with the thyroid. TPO, which is thyroid peroxidase, it's antibodies that the thyroid makes, can be helpful. And reverse T3 can be helpful. Reverse T3, you usually have to send out. It's super expensive. It's kind of cool to know about it. Does anybody know about reverse T3? Have you ever checked it before? Reverse T3 is when T3 is actually converted into reverse T3. And it's really interesting because reverse T3 is high in mammals that hibernate. So like bears and stuff like that in the winter, the reverse T3 gets really high. And what does that do? That slows their metabolism down. So if a patient has a high reverse T3, then they're obviously going to have a lot of low thyroid symptoms. So, but you know, the treatment is necessary with whether it be TPO or reverse T3. The initial treatment is, you know, more T3 anyway. But there are some other things that can factor into that with lifestyle and diet and stuff. But that's, you know, that's later on, and that's a progression. Let's see. Yeah, and TSH, I kind of mentioned it, but TSH is a good indicator of T4 levels only. So you'll see it. You'll see it with a patient. You'll see they're on levothyroxine 100 microgram. Their TSH starts out at like 4. They're on levothyroxine 100 micrograms. They come back, their T4 is 2. Their symptoms aren't necessarily better. I mean, they might be better a little bit, but they're not optimal. And you have a hard time knowing what's going on if you don't know what their T3 level is. So that's why T3 is so important. So important. We see those patients all the time that their levothyroxine levels are normal, their TSH level is normal, so they don't get their thyroid changed at all. But they do a lot better with T3. So here is the role of iodine. There's a lot of controversy on this, and iodine is a very you can get too little iodine and too much iodine. So if you get too much iodine, you know, you can get thyroid resistant. And too little iodine, you can't make enough of your own thyroid. So just be aware of it. There are supplements out there that, you know, help to support thyroid function with good doses of iodine in them. And some of them, you got to be careful necessarily because some of them do have really, really high dose. So, okay. Case study. Does anybody have any questions yet on thyroid function? Yes.
I'm trying to figure out why is it that the T3 does not affect your TSH? I'm trying to get my head around that.
The question is, if you couldn't hear that, why does T3 not affect TSH? You know, that is really a great question, and I don't know how to answer that off the top of my head. But TSH, I really don't know. I have a good reference on that, and I can get some more information if you want to get to me after class. But I will tell you that clinically, that's what you do see also. But a lot of times, most patients aren't on just T3, so that's why you don't see it that often. That was a great question, though. We have another question? Yes?
Can you expand on the connection between birth control pills and the thyroid? And I think that is a question.
Yeah. The question is birth control pills and how it affects thyroid. So birth control pills will increase protein binding of thyroid. So there won't be as much free thyroid to work at the receptor site. Okay, case study. So JS is a 44-year-old woman. She complains of fatigue, weight gain, decreased libido, depression. These are, you know, all symptoms of low thyroid. Realize this though, this is also, all of these are symptoms of low testosterone also. So don't forget about testosterone. And yes, women have testosterone and need testosterone also, not just men. So what do? She's on fluoxetine because she's depressed, and she's on levothyroxine 100 micrograms. This is this happens so commonly. So her TSH now, when she's on levothyroxine, is 1.9. So here's a normal 0.5 to 5. Just for simplicity reasons, I didn't put units in here. Don't get hung up on units. You know, trust the lab you're using. Try to use the same lab all the time. So, you know, when you follow up with the patient and keep doing levels, make sure you're using the same lab. And their reference ranges are usually pretty good. So use their reference range. And what's important is that you treat patients, not lab levels. Free T3, so 2.6 to 4.8 is normal. Her free T3 is 2.3. Free T4 is 1.5. So if you look at these ranges on T3 and T4, what we try to do is, this is very, very common. Usually, when I see labs like this, I don't even need to see this. I don't even see they're on levothyroxine. Usually you can see if somebody's free T3 is low and their free T4 is normal, you can almost guarantee that they're on levothyroxine. We see this all the time. Now, I'm gonna say this. We see, patients that are already having issues. They've been on levothyroxine and it's not working. And for whatever reason, their clinician's not listening to them. So they are seeking another way. So, and some patients, obviously a majority of patients maybe, do just fine with levothyroxine. I mean, levothyroxine is the most popular prescribed drug in 2016, right? And a lot of those patients do just fine because they're converting fine to T3, they're doing just fine on levothyroxine. I usually see the patients that fall through the cracks. So here it is. So the T4 is normal. So we don't really need to change that necessarily. So a common regimen would be add 15 micrograms of sustained release T3. And they would take that every morning. And in theory, the T4 is not going to change, and we're only just trying to increase the T3. So 8 weeks later, TSH 1.5, free T3 4.1, free T4 1.5, patient symptoms resolved. Another thing that we could do would be we could combine the T4 and the T3 into one capsule, 100 size 15 microgram, and they can take that once a day. That's another option. That's the beauty of compound is you can customize it to that patient. So let's talk about testing a little bit. I think I have it. Okay, let's just, I don't want to get into that yet. So let's talk about testing of thyroid and many hormones actually. So what happens if this patient comes back 8 weeks later, they're taking their sustained release T3, an hour later they get their labs checked, and their T3 is like 5.2. What would we do? Their T3 is like 5.2, which is above normal. Would we be really reactive about it?
Don't take it right before your lab test.
What's that?
Don't take it right before your lab test.
That's one of the options. Don't take it right before your lab test. So then you don't take it before your lab test, and then your T3 is 2.3. And then, right? It could, well, it's going to be back down to baseline probably.
If you're on a sustained release.
If it's 24 hours, probably not, because it's not going to last 24 hours. So here's one of my points, is that with thyroid testing, especially with T3, T4 is not affected as much, but it is. But remember, T4 has a half-life of 3 to 4 days. So with T3, it's very important that you know the timing of the dose. So if they took it an hour after blood draw, and I recommend an hour to 2 hours, and obviously that's not always important, but this is why labs are a tool to go along with symptoms and history. Let's not get too jumped up about labs, okay? So if their level did come back 5.2, then I would ask, well, how do you feel? Well, I feel great. I don't have any tachycardia. I don't have any hot flashes. My symptoms are resolved. Great. Then, let's not make any changes. But if you see that, sometimes you'll see, I see all the time with clinicians like, oh, they got too much thyroid. Well, and one of the ways if you want to check that the next day, if you check it 4 hours later, their thyroid level will be back down into the normal range. So, let's use labs as a tool to monitor patients. Let's not make them black and white. So what if the TSH level comes back and it's 0.1? Do we get jumped up about a TSH level of 0.1 when we suppress a TSH? Do we get really jumped up about that? I know sometimes we do, but remember TSH is a pituitary hormone. If they have optimal thyroid levels, their TSH is going to be suppressed because the pituitary is not telling the thyroid that we need more hormone. So, and speaking of that, and a suppressed TSH, I know I learned in pharmacy school. I think they still teach it. I think they teach it in med school because I still hear it out there. Is that too much thyroid causes osteoporosis, right? And there's one study to show that. And when you look at that study, that those women, it was mostly women, and they were post-menopause. And you know what happens when we go post-menopause? We don't have any estradiol, no progesterone, no testosterone, which is, those three hormones are very, very important for our bone health. So let's not blame it on thyroid. It might have been something else going on. You know, association does not prove causation. So upper range of normal. Can you guys see that? Can you guys see that bug?
Yes. Yeah.
It's kind of annoying. There's two of them back there. I don't know if it's behind the screen. I think it's behind the screen. It's interesting. It was following my pointer. So here, treat patients, not lab levels, and you know, realize too that compliance. Okay, so we get this all the time with many hormones. In our office, we specialize in hormone balancing. So we get a lot of calls about hormones from providers all over the Pacific Northwest. And you know what we'll commonly see when somebody's T3 is, we'll come back and they'll say, well, their T3 is like 2.2. You know, Shawn, I don't think there's any T3 in this. There must not be any T3 in this. And then I look at their history and I said, well, you know, it looks like the patient filled a 3-month supply like 6 months ago. You might want to ask them how compliant they are. And compliance. You know, I cannot get over that, because that is usually the case when it comes to labs being off. Now, that's not always the case. Sometimes we haven't educated the patient right. I had a doctor one time, and he called me and he said, "Shawn, I don't think you put any testosterone in this guy's testosterone. His testosterone's back down to baseline." Well, when's the last time he used it? Well, yeah, it's been a couple days. He said it's been a couple days. So we have to know those things. And here's another thing with thyroid, just a little side note. And we see this all the time, and this can kind of get a little bit frustrating, because we're putting the patient through extra tests and extra time and blood draws we don't need it. Have the patient come in, they talk to the provider, well, yeah, we're going to check your thyroid. And the patient says, well, I haven't been taking my thyroid for like, 2 months. Do not draw their blood. Do not draw their blood. It is a waste of time. Complete waste of time. So don't draw their blood, don't check their levels. Tell them this. Okay, let's start you back on the thyroid dose you were on. And how long do we have to be on thyroid before the labs are stable? TSH anyway. T3 would be affected the next day. T4 would take, a few weeks. How much? 4 to 6 weeks? Yeah, I go 8 weeks. I just say 8 weeks because TSH, believe it or not, can take some time to stabilize. And that's why when you're switching somebody from thyroid to thyroid, let me tell you, it is not an exact science by any means. It is not an exact science at all. I have conversion charts where, to help to go from levothyroxine to porcine or back and forth or to a compounded product, but it is just a guideline, and that is it. We have to treat the patients, we have to monitor them, and we have to be patient. Even 8 weeks later, especially if they've been on high-dose porcine thyroid, when you're switching them over to a standard release product, it's going to take a while for their TSH to stabilize. So 8 weeks later, if they're feeling better and their TSH is like 8, don't get too freaked out. If their T3 and T4 levels are normal, that's basically their T3, just keep going on the right track, and it might take up to 6 months to stabilize. Realize that it's not something that's super, super quick. And this is what I tell patients about, especially if you're diagnosing them for the first time. You didn't wake up one morning, unless they had thyroidectomy, you didn't wake up one morning and all of a sudden you had no thyroid hormone. It happened gradually over time. Well, when we balance your thyroid hormone, it takes some time, so just be patient. So does anybody have any